Welcome to the second day of the IWMF Virtual Ed Forum. I'm Carl Lissman, a patient diagnosed in 2017 and a trustee on the IWMF board. When I was diagnosed, I naturally first thought about what this rare blood cancer meant to me. Then, I suspect like many of you, my thoughts quickly went to what does this mean for my children and my grandchildren? Specifically, I wondered, was I going to be passing this on to them? Today, I have the pleasure of introducing Dr. Mary Lou McMaster, who will present information on her 20 plus years of work on familial WM, an important topic to almost all of us and something we need to know more about. She started the first national registry for familial WM, which now numbers approximately 100 families. Dr. McMaster has worked closely with the IWMF for many years, including speaking at several of the in-person ed forums. She works at the National Cancer Institute, where she also serves as a captain in the U.S. Public Health Service Commission Corps. At the conclusion of Dr. McMaster's presentation, we'll hold a Q&A session. Thank you for being with us today, Dr. McMaster, and I'll now turn this over to you to begin your presentation.
Thank you, Carl, for that very kind introduction. I'm going to begin sharing my screen. I would like to offer also my congratulations to our new Kyle Award recipients and to congratulate the IWMF on its forward thinking to ensure that the progress that has been made over the last 20 years or so in Waldenstrom's research continues to move forward and keep the momentum that has built up over this period of time. It's really important for the field and for our making progress continue. So it's a terrific opportunity that you're providing. So here are my disclosures. As Carl said, I've been interested in understanding predisposition to Waldenstrom macroglobulinemia, which I'll refer to as WM from here on out, for much of my career at NCI. And our questions are pretty basic. We'd like to know why some people seem to be more susceptible to developing Waldenstrom's. And related to that, why does Waldenstrom sometimes cluster in families? Are there any factors that increase the risk to develop Waldenstrom's? Could these be genetic, environmental exposures, or lifestyle factors? The family study at the NCI was begun in 2001, and what we have done during that time is to try to identify families having 2 or more family members diagnosed with Waldenstrom's, or because we suspected early on that there might be some cross reactivity amongst different B-cell tumors, we also were interested in enrolling families that had 1 patient with Waldenstrom's, but at least another relative with a related B-cell cancer, such as chronic lymphocytic leukemia. And then because it's important to have some frame of reference for comparisons, we enrolled a limited number of families having only 1 member with Waldenstrom's and no known family history. The people who enroll in our study fill out a number of questionnaires related to their family history of cancer, and their own individual medical and environmental exposure history. We ask for permission to obtain pertinent medical records because, as you know, it's very important to absolutely verify the diagnosis. And we obtain a blood or saliva sample from everyone who participates for genetic and other studies. Our approach has been multi-pronged. The high-risk families represent one arm of our approach to try to understand predisposition. We also, when we're able, incorporate case control studies, population registries, and population genetics, because what we would like to do is to be able to eventually make connections that not only affect familial Waldenstrom's patients, but also non-familial patients. So what have we learned? First of all, how common is familial Waldenstrom's? This is a rare disease overall, and familial Waldenstrom's is rare, but it's not nearly as rare as we first thought. We actually now have about 150 families enrolled in our registry, and there are similar registries that exist elsewhere, both in the United States and abroad, notably in France and in Sweden. We know in a referral hospital setting that about 5% of Waldenstrom's patients will report having a family member with Waldenstrom's, and up to 20% of Waldenstrom's patients will report having a family member with a related but different B-cell tumor. So one of the first questions we asked was whether environmental or lifestyle factors play a role in Waldenstrom's susceptibility. And to explore this question, we made use both of our high-risk family cohort and also case control studies. So the question was, do environmental and lifestyle factors play a role? Both the family studies and the population studies, which involve mainly non-familial patients, agreed in their results, and that yes, these factors do play a role. Infections, autoimmune disease, family history, some chemical or occupational exposures, and some lifestyle factors. They all seem to play a role. Now, I will say that these first studies were largely exploratory, and so we didn't break chemicals down into specific chemical exposures, but rather grouped them into classes of chemical exposures. And the one that really rose to the top was chemicals related to the occupation of farming. So pesticides, herbicides, fertilizers. And this was actually not a surprise because we have known for decades that there is what's known as the lymphoma belt in the United States, which cuts right through the breadbasket of the United States, the Midwest farming states. And so this came as no surprise, but we were interested to see that it held up for Waldenstrom's as well as other forms of B-cell lymphoma. We also wanted to know whether there are genes that predispose to developing Waldenstrom's macroglobulinemia and what the inheritance mechanism might be. And to examine this question, we made use of our high-risk family cohort, population genetics, and case control studies again. So just to review, I know many of you have heard these kinds of talks before, but I want to be sure that we're all on the same page. So any given cell in the body contains its genetic complement. The genes are organized into chromosomes, which reside in the nucleus of the cell, of virtually all cells in the body. A change in a gene can lead to dysfunction of that gene or non-function of that gene. And that is ordinarily the mechanism by which cancers develop initially. So this was something we were very interested in trying to understand. So this graphic just shows a cartoon of a change that's occurring in the DNA. It may or may not fall within a known gene. It may fall within a regulatory region related to a gene. But this is what we have been looking for the past several years. Since the genes are organized into chromosomes, we can also look at the chromosomes themselves for large changes such as pieces missing or pieces that have been duplicated that might be considered to have a genetic effect. Now, it is very important to understand the difference between a gene change that can be passed down to offspring and a gene change that cannot be passed down to offspring, particularly in the setting of the discovery of the MYD88 gene and other genes that are known to affect the Waldenstrom tumor cells. So we call these, when these genes that are operating in the tumor cells alone, a somatic variant. So these occur in non-reproductive cells. They cannot be passed on to offspring. And so all of the cells in the child will represent the normal genes, and there will not be any cells affected in the offspring. In contrast, a germline variant is present in the reproductive cells, either the egg or the sperm, and therefore it can be passed on to offspring. And if it is, then usually all cells in the offspring are affected, including their reproductive cells. And that's how the disease can be passed from generation to generation. So I mentioned the MYD88 gene. You're all very familiar with it by now, I'm sure. The MYD88 mutation occurs in more than 90% of Waldenstrom tumors. It's also seen in a much smaller proportion of other B-cell tumors, including chronic lymphocytic leukemia, CLL, marginal zone lymphoma, MZL, and DLBCL, or diffuse large B-cell lymphoma. It's also been shown to occur in at least 50% of MGUS cases, but it has not yet been seen in the germline, and there's a fair amount of evidence to suggest that if it were to occur in the germline, it would probably be lethal to the fetus. So it is not passed from parent to child. It is not a susceptibility gene. So what does genetic susceptibility mean, that term? When we use the term genetic susceptibility, we are referring to one or more genes that are important for normal cell growth and that have developed changes, or what we refer to as variants, that affect their function. These changes are present at birth, and they can be passed from one generation to the next. They may or may not be able to cause Waldenstroms by themselves. In some cases, one could envision a situation where you would need more than one gene change or a combination of gene variants and environmental factors before a cancer would develop. So again, to review, only germline mutations can be passed down from parent to child. So you see on the left, the somatic mutation that only involves a portion of the body, but certainly not the reproductive cells, whereas a germline mutation will be in the reproductive cells themselves. A second mutation must occur before cancer can develop. So having inherited a gene change, that poses susceptibility to that second mutation that then results in the cancer development. So genetic susceptibility includes inherited variations. It may be affected by environment or lifestyle, and these two things often affect each other. And as a result, a cell that carried one mutation in a gene, in the normal copy of the gene, a mutation develops as well. So now that cell has two copies of the abnormal gene and is ripe to begin to develop the cancer. So genes can have different effects, and it's a fairly simplistic model, but I think it's useful to think in this way, that there are genes that have a big effect. So these tend to be very rare. If they do occur, they lead to a high risk for the disease in question. They may be modified by other genes or environmental factors. And they are amenable to certain research strategies, such as looking at the chromosomes, doing what's known as linkage studies, and genetic sequencing studies. So these are the tools that we use to look for these genes of big effect that would be expected to be rare. On the other hand, we have genes with a small effect. These are different. These small changes occur commonly in the genome, but they lead only to a small increase in risk. So in order to actually develop disease, a patient would have to have similar changes in many genes and probably also certain relevant environmental exposures. And the main strategy that we use for investigating these kinds of genetic changes are various types of association studies. And I'll talk more about these in a bit. So we're thinking about genes with big effects and small effects, and how might they be related to the development of Waldenstrom's. In a simple genetic disease, it is more common to see a big effect rare variant in gene. These are seen only in patients with the disease, and the single variant alone can lead to the disease. On the other hand, did you lose my slides? I lost the slideshow, sorry. There we go. So in considering complex disease, and cancer is generally considered a complex disease, we're more often thinking about common changes. And these, when I say common, the definition is that they can be carried by up to 5 in 100 people in the general population. And a single variant is going to have no effect, no measurable effect, or else a very small effect. And so it takes many of these variants to cause disease. So again, genes can have different effects. And we first looked for genes with big effect. And the reason for that was that we had a number of families that had many people affected with Waldenstrom's. And the pattern in the family looked very characteristic of what we call autosomal dominant transmission. So it looked like a genetic disease in these families. There were many people that were affected. And so that is the type of situation where you're most likely to find one of these rare variants responsible for the condition. So we used our high-risk families to study this type of change. And again, these lead to a high risk for disease. They may be modified by other genes or environmental factors. And we use these strategies of chromosome linkage and sequencing studies. So in searching for rare Waldenstrom's genes, what are we looking for exactly? The genes contain the instructions to make proteins. And an analogy would be genes can have changes in spelling. So if you take the word color, for instance, you might have a change, such as adding the U, like our friends across the pond do, but the word itself doesn't change. The meaning hasn't changed despite having that variant. You might have a different change, like changing the R to an N, that leads to a totally different meaning. Or you might have changes in the spelling that lead to a completely dysfunctional, meaningless word. We call these changes variants, and genetic studies look for variants in genes. So our sequencing studies uses the patient's DNA, the germline DNA, not the tumor's DNA. We look for variants in the spelling of the DNA of the genes. We make use of the fact that the same DNA spelling is inherited. So you inherit the spelling of your genes from your parents. For our studies, we concentrated on the genes themselves using what's known as whole exome sequencing rather than whole genome sequencing, which actually also looks at the regions between genes. This approach is best for identifying rare genes with big effects. And much to our disappointment, to date, we have not identified a smoking gun that accounts for Waldenstrom's in many families. What we did find were many changes in genes that are known to be important in B cell development and B cell function. But the issue that is holding us back is that so far we are not seeing the same gene affected in more than one family. So this suggests to us either that this is not the mechanism behind the development of Waldenstrom's in families, or we have an unfortunate situation where each family is going to have a genetic change that is private to it, that family, and not be found in other families. And this is difficult because it's much more difficult to prove causation in this situation. And it means that every single family would have to go through the process of identifying the many variants in B cell related genes that family carries and trying to determine whether there have been functional effects induced by the variant. So that's a daunting task and not really practical in today's clinical environment. So we turned our attention to genes with small effect. And to examine this possibility, we were able to include both familial and non-familial patients because these common genes would be expected to be as important for the development of non-familial Waldenstrom's as familial. So again, just to review, these common gene variants lead to a small increase in risk. So the disease results from a combination of many gene variants and probably environmental factors as well. And we use association studies to study this. So I think the best way to think about association studies is mile markers on a highway. We don't look at specific genes. Instead, we know the precise location of many hundreds of thousands of mile markers in the highway of our genetic material. And by isolating a particular marker, then we can look at the area around it, which often contains genes that are suspected to be involved. So using this mile marker approach, we see that the mile markers we choose because they're prone to common changes. And each one of them marks a gene or a gene region. And to do these kinds of studies, we look at the genomes from many different people, both with and without Waldenstrom's, to compare, because we expect to find these changes even in people who don't have Waldenstrom's. What we want to see is whether patients with Waldenstrom's have a particular mile marker change more often, statistically and significantly more often than people who do not have Waldenstrom's. So there are a number of types of these association studies. The first one that we did was a family-based association study. And here, instead of looking at all possible mile markers, we actually focused on specific genes that we knew were important in the function of the immune system. And we did find a few genes that may contribute to risk, but those have not yet been confirmed by us or others. And we really can't say that they are causative without that confirmation. More recently, we performed what's known as a genome-wide association study. And in this kind of study, we scanned the entire genome using these genetic mile markers. And we compared the marker results from many different Waldenstrom's patients with those from healthy people. And we did a particular approach that was very helpful, actually, and allowed us to use our families in interesting ways. So we know that Waldenstrom's clusters in families. We know that the relatives of Waldenstrom's patients have increased risk for Waldenstrom's or related B-cell disorders. And we haven't yet identified high-risk predisposition genes. And this suggests that one of these or some of these common or small effect variants might be contributing. So we reasoned that a study that was enriched with familial cases might also be enriched for susceptibility genes. So what we did to begin with was to take 217 Waldenstrom's cases, and we spiked those cases with familial patients. So 40% of that collection was familial Waldenstrom's. And then we compared the results in those individuals to almost 4,000 controls. Now, we'll say that everyone in this study was of Northern European ancestry. And so we had to account for age and sex and ancestry in interpreting the results. We then followed up the results in a new sample of 312 Waldenstrom's patients, but this time we wanted to make most of them non-familial because we wanted to see whether the findings were limited to the familial patients. So in this case, only 5% of the sample was familial. And we used 500 controls, again of Northern European ancestry, and accounted for the same factors and also the laboratory in which the genotyping was done. And here are the results. And this is a little small, but I think you can see that we found that there are at least 2 regions of the genome that can contribute to Waldenstrom's susceptibility. The largest of these, the largest effect, was on chromosome 6, on the short arm of chromosome 6. And then there was also a region on the long arm of chromosome 14. There are probably more regions to be discovered. And we don't yet understand how these regions contribute to susceptibility. We have done some functional studies that confirm that they are active in regulating important genes, but we don't have confirmatory proof yet. And it's more evidence to our mind that Waldenstrom's likely results from a combination of events rather than one single gene change or one single gene variant. So we're now collaborating with a large international consortium to confirm and extend these findings. And this includes many of our colleagues from around the world have contributed samples for this study. We will have about 1,350 Waldenstrom's patients and more than 20,000 controls. The data have been generated and are currently undergoing preparation for analysis, and we hope to have confirmatory analysis within the next year. Our hope is that we will confirm our original findings, and also because we have a much larger sample, we'll be able to discover additional regions of the genome that are contributing to susceptibility. We estimate that approximately 25% of the heritability of Waldenstrom's can be attributed to these kinds of genetic changes. So another question that has always come up is whether family members of Waldenstrom's patients are at risk for other conditions. And to look at this, we incorporated both our high-risk families and population registry studies. What we did find was that relatives of Waldenstrom's patients have increased risk of some B-cell disorders, absolutely an increased risk for Waldenstrom's. But the family members of a Waldenstrom's patient are also at increased risk for other forms of non-Hodgkin's lymphoma and chronic lymphocytic leukemia, although at a much less rate. Hodgkin lymphoma is unlikely based on our results, and multiple myeloma, I think, is a big maybe at this point. We certainly see multiple myeloma overrepresented in our families, and this is an observation that is shared by our colleagues who have collections of families elsewhere. But the numbers are not great enough for us to be able to say with confidence that a family history of Waldenstrom's will lead to an increased risk of multiple myeloma for relatives. There's absolutely an increased risk for MGUS, and that MGUS, or monoclonal gammopathy of undetermined significance, is usually of IgM type if there's a family history of Waldenstrom's, but not always. And finally, in our study, we did see several relatives who had an elevated level of IgM, but no monoclonal component to it. So a polyclonal elevation of IgM. So this might be another familial risk. In rare occasions, we have seen this polyclonal IgM elevation progress to a monoclonal IgM and ultimately progress to Waldenstrom's, but that has been a very rare occurrence, and we're not able to say with certainty that this is a true risk factor. So we talk quite a bit about risk, and I think it's important to spend a minute or two on trying to explain how one interprets risk. When you hear about or read about studies that address risk, those will usually be couched in terminology, either relative risk or absolute risk. And I'm going to give just a really fictional example here to try to illustrate the difference. So suppose there's a study and it says that the chance of a heart attack in a person who has no history of caffeine intake is 1%. And the chance of them having insomnia is 30%. They then find a relative risk of twofold or 2 times the risk in both situations. So here we're saying that a person who drinks 3 cups of coffee has twice as likely chance of developing a heart attack and twice as likely a chance of developing insomnia. What does that really mean for that individual? Well, the absolute risk in the chance of a heart attack is there's 2%, which is a change of only 1%. Because in this example, the chance of a heart attack is rare. In contrast, the chance of insomnia is high to begin with, even in the absence of caffeine. And if you double that risk, then it becomes very high. And the increase in the absolute risk is 30%. So when you hear about relative risk, you have to weigh that, understanding that Waldenstrom's is a very rare condition. So to take it one step further, what does this mean for Waldenstrom's risk? So I'm simplifying this again, and I'm showing sort of the worst case scenario. We know that for anyone walking on the street with no family history of Waldenstrom's, they have a 0.0005% chance of developing Waldenstrom's. In contrast, a woman's risk of developing breast cancer over her lifetime is about 12%, and a man's risk of developing prostate cancer is about 11%. If you add in a family history of one of these diseases, if you accept a 20-fold increased relative risk of developing Waldenstrom's and a 2-fold increased risk of developing breast or prostate cancer, the risk of developing Waldenstrom's is still 0.01%. Whereas the risk of developing a common cancer is almost 1 in 5 to 1 in 4. So again, the best way to interpret individual risk is looking at the absolute risk. And absolute risk is very influenced by the rarity of the condition. And the rarer the condition, the less the absolute risk will be affected. So how do we think about risk in 2021? We have evidence now that genetics, environmental factors, and lifestyle factors all contribute to risk. We don't yet have enough evidence to know which is more important, but we suspect that they all work together. So the take-home messages from my talk would be that a single gene is not likely to account for all familial Waldenstrom's. We've looked carefully. Other groups have looked pretty carefully. We have found linkage to more than one region in the genome. We have found associations with more than one small effect gene. And we have evidence suggesting that environmental and lifestyle exposures might contribute to Waldenstrom's. Secondly, risk for Waldenstrom's depends on a combination of genes, environmental exposures, and possibly lifestyle factors. Should healthy people get screened? Well, the answer here is maybe. We know that they are at low risk to develop Waldenstrom's, even if they're in a family. And new data, however, suggests that MGUS may have health effects apart from cancer. So we know that people who are diagnosed with MGUS should be followed medically. But the question really is, in terms of trying to determine whether someone is at increased risk to develop Waldenstrom's, should family members be screened? I would say that if it's very much personal preference and how an individual deals with this concept of risk, knowing that one has a condition such as MGUS that has a known conversion rate to Waldenstrom's can be very unsettling for people. And until we have a cure, or until we're able to prevent the progression of MGUS to Waldenstrom's, that could be a pretty big psychological burden for that individual. So in general, we don't recommend screening outside of the context of a research study. But we also recognize that in the real world, people are curious and there are people who want to be screened. And so for those who do, it's very important that they follow up with their physician and probably get an opinion from a hematologist or oncologist who is familiar with Waldenstrom's, who can advise them. But they would need to be followed thereafter. But really, the bottom line is that all of these results, because Waldenstrom's is such a rare disease and because familial Waldenstrom's is even rarer, it is very difficult to make definitive conclusions from the data that are available today. And so we need more young people getting into Waldenstrom's research to answer these questions and to confirm these original findings. So I thank you very much for the opportunity to spend some time with you today. I'm really appreciative of my relationship with the IWMF over so many years. I'm very grateful to all of our families and our Waldenstrom's patients who have participated in this research, in some cases for up to 35 to 40 years. And my team at the NCI and our many, many scientific collaborators and colleagues. And with that, I will conclude. If you would like more information, I believe the slides will be available, but certainly I can provide that.
Thank you very much, Dr. McMaster. We appreciate your excellent presentation. I'm finding, obviously, this is a much more complex question than I thought it was. And I guess I would have loved a simplistic, there's nothing to be concerned or think about, but obviously that's not quite the case. So thanks for the great presentation. we are now ready to take some questions. There have been a lot of excellent questions added in the chat. I don't know that we'll get to all of those with the questions we've got so far, but we will try and answer as many questions as we can now. So, Dr. McMaster, if you're ready to take the questions, we'll get started with the first one.
Sure.
Okay, so the first one is, do patients with a familial WM have a shorter time to progression and or poorer outcomes?
So I think the answer to this question is not completely settled. There certainly is some evidence that in response to treatment, that familial patients do not do as well with some treatment. We do not have a treatment component to our study at NCI. So patients are treated in their community or at academic centers as they prefer. I can say that survival in our study has ranged from 5 to more than 30 years. And we have not yet reached median survival in a study that's now in its 21st year. So at least in our familial cohort, we are not seeing poorer outcomes, but it has been reported. So I think this is an area that deserves further dedicated study to understand what exactly is going on.
Okay, thank you very much. Our next question.
So this is related, but not exactly the same. How do relatives usually present with the same symptoms, the same picture clinically, and do they have similar disease courses? So again, in at least one study, patients with a family history of Waldenstrom's were diagnosed at a younger age and with higher levels of bone marrow involvement and generally higher IgM levels at the time they were diagnosed. But those with a family history of other B-cell disorders, not Waldenstrom's, weren't any different in their presentation than non-familial Waldenstrom's. Again, in our familial cohort, we have also published on this, and we saw no meaningful differences between patients with a family history and those without in terms of presenting symptoms or burden of disease and disease course. And I already mentioned our survival. We're still, the survival in our familial cohort has been really remarkably good.
Yeah, that is encouraging news. So thanks. Our next question is, multiple myeloma considered a familial risk factor for WM?
Yeah, so I alluded to that in my talk, but I think, again, the question is, as will be the answer for many of these questions, is that we don't know yet. For groups that have collected families, many of those groups report an excess of multiple myeloma in the families compared to what we would expect in the general population. But when we looked in the registries where we weren't taking, we were looking at all comers, not just familial patients, but asking the question, if a person is diagnosed with Waldenstrom's, does their relative have a higher risk of multiple myeloma? And there, the risk was not increased. Now, this might be purely a question of numbers, and that if we had a large enough sample, we would see it. Or it could be a matter of the population-based studies also include mainly non-familial patients. So it's Waldenstrom's patients, but their family members may never develop any sort of B-cell disorder. So it may be that once, if you have a family history and you yourself are predisposed, then you might be at increased risk for myeloma. But the problem there is that we don't know that a family is a family until the second person is diagnosed. So that has a way of distorting the data a little bit. So the question of whether there is a relation between Waldenstrom's and autoimmune diseases, and if so, which autoimmune conditions increase the risk of progressing from MGUS to Waldenstrom's? Okay, well, we have a large case control study with several thousands of cases and controls, and a very large population-based registry study that both confirmed an association between Waldenstrom's and autoimmune disease overall. And that is consistent with what we see in families. The only specific autoimmune disease that was associated with elevated risk for Waldenstrom's was Sjogren's syndrome. Now, a problem that we have in interpreting these data, or there are two actually. One is that their autoimmune diseases represent a very large collection of individual diseases. And so if we can see the association in the aggregate, but when you start parsing out individual conditions, some of them are quite rare on their own. And when you take a rare condition and try to associate it with another rare condition, you really need just huge numbers in the sample to try to answer the question. The second problem is what we call the reverse causality problem. And that stems from our knowledge that the IgM molecule is an immunoglobulin, an antibody, and it has properties of an antibody. So it can itself attack tissues within the body. And we know that Waldenstrom's patients very frequently have autoimmune manifestations related to their IgM. So and this is also true in MGUS. So it is very difficult to say which came first in some cases, the autoimmunity or the monoclonal IgM. So that is always something that when you're looking at studies that address this question, you need to look at how the diagnoses were validated and what the temporal relationship was, if that can be ascertained.
Okay, thank you. I guess we're on to our next question. Is there any relation between Are there any known or suspected triggers that activate an increase in IgM levels in someone with MGUS, such as a virus, disease, stress, or anxiety?
So far as I know, that study has not yet been done. We have looked at the association of these various factors with Waldenstrom's compared to people who are healthy, but we haven't looked yet at patients with MGUS to see whether their risk of progression is greater. And that's where some of our younger investigators, including our Kyle awardees, may prove very prescient and beneficial to our understanding of this process. Because as of today, I'm not aware of any research that addresses this specifically.
Okay, very good. Thank you. Our next question. What are the known environmental factors that may lead to WM?
Okay. So as I mentioned in my talk, the strongest association we saw was for chemicals that are related to farming. There are several environmental factors that have suggestive evidence of an association. One thing I did not mention in my talk was Agent Orange. And although there are no specific studies of Agent Orange and Waldenstrom's, the great research scientific monolith of the United States government has determined that Agent Orange exposure entitles service members who later developed Waldenstrom's to compensation. And so that determination is based on sort of a weighing of a lot of evidence within the Department of Defense, but that has never been published. But the United States government recognizes Agent Orange as an environmental factor that increases risk for Waldenstrom's. I think overall, sort of the common theme amongst the environmental factors we're aware of is twofold. One is what's known as chronic antigenic stimulation, and this is related to infections and autoimmunity, but also other things that can disrupt immune function. So most all of the environmental factors that have been identified to date will fall generally into one or the other of those two categories.
Okay, thank you. And we had specific questions about Agent Orange, so thank you for getting right to that point. Why is there a greater likelihood of WM in people of Ashkenazi Jewish descent?
I do not know. About the only thing I can say about that is that there are certain populations in the world that are fairly small and fairly genetically distinct because of either, usually it's geographic considerations, but we often find in those populations what is known as founder mutations. And they're mutations that arose many, many, many generations ago. But because the population is a small, fairly confined one in terms of the breeding characteristics of the population, the mutation stays within that group. You will find it outside, and so that would be the main my main hypothesis, that there might be some sort of a founder mutation or founder effect in the Ashkenazi Jewish population, but that's pure speculation on my part.
Okay, thank you. Should my grandchildren be tested for these mutations?
Okay. So this is an important point because, again, it gets back to this notion of interpreting risk. So, and the difference between germline and somatic mutations. The mutations that are known to be important in Waldenstrom's are all somatic mutations. They are only in the Waldenstrom cells. We don't have any evidence whatsoever that they are being passed down from patient to their children, to their grandchildren. Now, the common genes that I spoke about, those, again, what we're looking at are not genes themselves, but these mile markers, which are genetic markers that are near genes, but actually can have an effect very, very distant in the genome. And they may affect multiple genes. So until we have confirmatory studies like this very large international study I mentioned that's ongoing, there's no ability to test, nor is there a reason to test, because we haven't proven the relationship yet. We see the association, but seeing an association does not prove causality. So no, the answer would be no.
Okay, thank you for that clarity. I think we're ready to get to our very last question. So here it is. If you are not born with the MYD88 gene, then how do you get familial WM?
So that is a very important question, and that is really the crux of my work and what we are continuing to hope to do. Again, we have hints, but we don't have a final definitive answer. What we believe is happening is that there is a genetic susceptibility, but that genetic susceptibility could be towards immune dysregulation. And then there's a secondary effect once a patient encounters some chemical or infection or other condition that affects their immune system and its ability to regulate itself. And at some point, that sort of would present an opportunity, if you will, for the MYD88 genetic change to occur. And then that is most likely the genetic trigger that leads to the development of the actual Waldenstrom's tumor.
Okay, Dr. McMaster, thank you so much for your participation today and for the great answers to the questions that we've asked. I want everybody to know that Dr. McMaster will be back this afternoon as a faculty member on the Ask the Doctor Q&A panel, so you'll have a chance to hear even more from her later today. In closing, I'd like to thank everyone who participated today and all of you who listened to this educational program. And actually, I want to finally thank our title sponsors, BeiGene and Pharmacyclics, Janssen, as well as Collectar Biosciences, the Treadway Foundation, and X4 Pharmaceuticals. The next presentation will start at 12:45 Eastern Time in the United States, so at the coming quarter of hour for everyone around the world. And we look forward to seeing you back then. Thanks again, Dr. McMaster.